Okay. Well, we have a bit of a decision point as a group at this point. I am going to do a session on motivational interviewing and recovery. And it's something that I care a lot about and we could spend a fair amount of time on. I think we had allotted 1 hour for the session. I think we're a little ahead of schedule. So would people rather take a little break and come back? Or would you like to just go into it now? What's the consensus of the group? Or do you have a preference?
We have to finish, or otherwise we will have half an hour interruption because we have the core event.
So would you like us to just go straight through?
Yes, I think.
Okay. Okay. All right. You guys do you need to stand up and stretch, or are you okay? Everybody's okay. Some people need to stretch. Okay. Take a minute to stretch. How many of you know anything about motivational interview? Do you have any motivational interviewing experts here in the group? How many of you have heard of motivational interviewing? You know a little something about it. You know a little something about it. You know a little something about it. Okay, good. And the term recovery means a lot of different things to a lot of different people. So, and in the States, and I guess in Canada, because one of our presenters this morning from Canada was talking about a recovery orientation. Does that term mean anything to you guys? And I'm not talking about substance abuse recovery. So if we use the term recovery as it applies to mental health, does that term mean a whole lot to people? Not so much. Okay. All right.
And it looks like it's gone along well. Tests are looking good. Blood test looks really good.
No.
Looks like you're doing great. You're doing just great.
Thank you.
The nurse briefed you on the follow-up care, I'm pretty sure.
Yeah, a little bit.
Okay, and so you've been over all that.
Some.
All right, now.
So are you taking your meds? You're taking those real regular, and
Yes, yes.
those are going okay. Any problems with the medication?
No,
So-
not that I know of.
Yeah, it looks like it's working for you. So the next step's up to you. I think if you just stay on the program that the nurse has outlined for you, if you you're going to our cardiovascular exercise program and
Yes.
working out pretty well there. You're doing all the work you need to do.
Stop it right now, okay? And now if I want to toggle back to the... Okay, let's toggle back right now. Okay, good. And the little controller? Okay. All right. So we'll begin. So I'm not sure, there are some people who were here this morning from my earlier presentation and some who were not, but I'm from the States. I work in an academic medical center in Iowa, which is in the middle of the United States. And I'm a psychiatrist, and I'm the president of an organization called the American Association of Community Psychiatrists. And I'm also one of the relatively few, this motivational interviewing network of trainers is an international organization of people who not only are interested in motivational interviewing, but who actually do training in motivational interviewing. And there's maybe 1,000 or 1,500 of those people internationally, and a very small minority are psychiatrists. So I'm kind of unusual in that respect. And that's where Iowa is in the States. I'm going to skip over this for now, but a bit about you. So we already did this. So very little knowledge base about motivational interviewing among this group, right? And it sounds like relatively little knowledge base about recovery among this group. So how ready and interested are you in learning a little bit more about this? Are you open to this? Okay, all right. Okay, so why? So I did a little bit. I know from some of you who were here this morning what you do, but for example, what's your background?
I'm a psychologist from Australia.
A psychologist, pretty widely used in Australia, actually. Yeah, you know about this. And you are?
I'm a graduate.
undergraduate?
Psychology. It's
Psychology.
my second.
Okay. And you guys?
PhD candidate.
In
Psychology.
psychology?
PhD for nutrition and epidemiology.
Okay, this is important in nutrition.
Yes.
Okay. And you're a medical student from Saudi Arabia, and you are
Clinical psychologist
from where?
from Greece.
From Greece, lovely. And you are?
I'm a watcher. A watcher.
Watcher. Okay. Turkey, we know who you are, and you are with her.
Yeah.
Okay. And you guys?
We are a child and adolescent psychiatry from Portugal.
Really? From Portugal,
Yeah.
really?
Yes.
Both of you?
Yeah.
Interesting. Okay. All right. And you are?
I'm a medical graduate and I want to follow child psychiatry.
Child psychiatry. Okay.
I'm a psychologist, clinical, complete.
Okay.
I'm a physicist.
Ah, what are you doing here? Wrong meeting? Okay, good. Welcome.
So I'm neurologist, psychiatrist, and I working in Montenegro and Serbia, and postgraduate neuropsychology.
Lovely. Okay. Well, it's a nice mix of people, and I actually think, and even the IT professionals among us and the physicists among us and the watchers among us might actually find this interesting. I think you might. Okay. So in the U.S., there's a lot of talk about this idea of recovery. I don't know if does that come up in Portugal at all? A little bit. Yeah. And it sort of has to do with what I said in my earlier presentation about the fact that I thought my job as a psychiatrist 10, 15 years ago, I thought my job was to decrease symptom burden. I really did think that was my task. If you had schizophrenia and you had lots of voices, my job was to reduce the voices. Okay? A recovery orientation says that's not necessarily your job. That your job is to help people thrive and live the best lives they can live despite the potentially catastrophic effects of serious mental illnesses. And that notion that facilitating recovery is what our mental health service system should be about there's been a big effort to try to propagate that notion and get people to buy into it. So a lot of people believe, and there's increasing recognition that facilitating recovery is the primary outcome that we're going to try to achieve. However, real-world strategies to do so are not certainly clear, and there's no consensus about what those strategies should be. It's unclear to a lot of people, and if you tend to be a concrete thinker, it's even more unclear. And I tend to be a concrete thinker. Tell me what to do and I'll do it. Okay? And so I liked the idea of recovery, but I didn't frankly know what to do about it. And the basic premise of what I try to convey in these kinds of workshops is that this business of motivational interviewing, which has both a spirit and a technique, if you were to get into that and to adopt that style and practice that actual set of technical skills, then doing that, you would be delivering mental health in a recovery-oriented manner, whether you called it that or not. So that this underlying motivational interviewing spirit, which was started as an evidence-based practice for the treatment of substance abuse disorders, is highly consistent with the core concepts of this thing we're going to call recovery, and that a broader application of motivational interviewing in mental health settings is a real, practical, teachable, and even measurable way for providers to enhance their capacity to facilitate recovery. So let's just spend a little time on what it is that we mean by recovery. What does it mean to be recovery oriented? So I don't think that's obvious. In the US, the big federal agency that oversees mental health and substance abuse services is called the Substance Abuse and Mental Health Services Administration. Big, giant agency, multi-billion-dollar budget. And the director of that agency 7 years ago said, today when you say recovery, people know what you mean. Well, clearly that's not the case in this room. But in most of the rooms that I go to in the US, that's not the case. People know that term as applies to addiction. They know what it means to be in recovery from an addictive disorder, but they don't know what it means as it applies to mental health. So, and yet, again, if you read lots of documents, like the big federal agency's mission statement is building resilience and facilitating recovery. That's the mission statement for this whole federal agency that oversees mental health and substance abuse in the US. A director of the Center for Mental Health Services in the US says the introduction of recovery into our national mental health dialogue is nothing short of revolutionary. Another director says recovery must be the common recognized outcome of the services we support. So there's a lot of lip service around recovery. And in the early 2000s, there was a presidential commission on mental health transformation in the US, and they basically built an entire sort of strategic structure about facilitating recovery and resilience. And Rosalind Carter, who was the wife of Jimmy Carter, the president in the 70s, who had a big interest in mental health, said the biggest change in mental health from 1978 to today is that we now know that recovery is possible for any individual with mental illness. Now that is often misunderstood because the word recovery, at least in the lay dialect, implies I'm better. You know, I've gotten over my illness. That is not what we're talking about. We're not talking about getting over one's illness. So what are we talking about? So one of the early proponents was a psychologist, Bill Anthony. I don't know if any of you are familiar with William Anthony's work, but he was really one of the important writers about this, 25 years ago or so. And he says recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. So it's almost like from the physical rehab world. So you have been in a terrible car accident and you're paralyzed, say, from, the neck down. And what is the job of the physical rehab doctor? It's, you may never walk or use your arms again, and there may not be anything I can do to help you with that. But now, what is going to take for you to thrive, despite this catastrophic event? Same thing here. You have schizophrenia, and maybe you're one of the 25% of people with schizophrenia who don't respond to medications. And, does that mean that your life is going to be lousy? Or what would it take for you to thrive in the context of this potentially devastating illness? Priscilla Ridgway is a person with lived experience. She's who writes about recovery, and she says it's the experiential shift from despair to hope, from alienation to purpose, from isolation to relationship, withdrawal to involvement, passive adjustment to active coping. Okay? A process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And what I'm showing you this, so these are the sort of components of a recovery-oriented mental health system. Again, this is from the U.S. federal agency that oversees mental health. Self-direction, okay? It's very individualized and person-centered. It's going to look different for different people. It's about empowering people. It's holistic, and it's not just about take your meds. It may be about a whole variety of kinds of things. It's non-linear. It's strengths-based. It involves peer support. Respect is key. There's responsibility for the patient/consumer. and hope, the transmission of hope. So all of these things, there's been this effort on the part of the U.S., lots of different players. And when you present this, you get a lot of head nodding. Everybody says, well, that sounds nice. Hope is good, you know. But the question often becomes, well, how do you actually do this? How do you translate this, right? And it involves, you know, broad things like overall health, making informed, healthy choices that support physical and emotional well-being. It involves having a stable and safe place to live. It involves meaningful daily activities such as jobs, school, etc. Relationships to social networks, community. Actually, one of the directors of this big federal agency, SAMHSA, who's kind of a personal hero of mine, I love what he says. So again, what are the outcomes that we're trying to achieve, right? Are we trying to achieve just symptom reduction? What are we trying to achieve? So he says this: a decent job, a place called home, and a date on Saturday night. Okay, that's what we're trying to achieve. So again, for the first half of from about 2000 to 2007 or 8, one of my jobs, I was supported by our state's mental health authority, and I would go around and talk to providers of publicly funded mental health services. And I was trying to get them to buy into this recovery orientation and stop spending their time just talking about whether you're taking your meds and doing these little checklists. And everybody was kind of agreeing, that sounds nice, hope is good, self-direction is good. But they were saying, I agree with it, but what exactly are you asking me to do differently in my office tomorrow? I'm still going to see this patient tomorrow. I'm still going to do this thing that I get funded for. What do you want me to do different? And so my hope and my strategy has become, so in about 2007, one of my junior colleagues who had been going around with me and giving these talks and seeing all these people nod their head and not know what to do differently in the office, she said, I have this idea. And she handed me this book on motivational interviewing. She said, read this and then let's talk. Now, I had heard of motivational interviewing because I knew it was something that had been around for a while and that substance abuse providers thought made a lot of sense. And I knew a little something about it, maybe like you. But I didn't really know what she was talking about. And I read about the first, she said, just read the beginning and then we'll talk about it. And I read about the first 30 or 40 pages of it, and it became crystal clear to me what she was getting at. And that was that, again, this overlay, that if you were to buy into this method of communication and this style of being with patients as your default, not pulling it out of your toolkit when you see someone who's dealing with a substance abuse problem, but as a default communication style, then regardless of what you call it, you'd be practicing in a recovery-oriented manner. Okay? So, and maybe what I'll do is I'll show you an example. I'll show you an example of what it means to have a clinical interaction not in a recovery-oriented, and not in an MI-consistent manner, and then an interaction in an MI-consistent manner. And I think you'll be able to see the differences, okay? So can we get back to the video? And for the watchers and the physicists and the IT professionals in the room, this goes beyond just a mental health clinical interaction. Every one of us has either been to a doctor or been with someone who's gone to a doctor. So let's take it out of mental health for a minute and just look at a clinical interaction that does not include anything that has an MI spirit or technique. And the setup here, and this is a simulation, but the setup is a very well-intending doctor.
Yeah, I
At the
walk
exercise
regularly.
program. So
And
you
this
walk-
guy has had a
Yes.
heart
Yeah,
attack.
good.
Walk regularly.
And he's his
You have to keep
cardiologist or
that up.
primary
The program
care
will be
doc.
over
And
pretty
we'll watch
soon,
about
but
5
just keep
minutes
up,
of this.
keep walking around your neighborhood. Try to like park some distance from the store, just walk in. If you keep your exercise going, I think that's going to go okay. Now, okay, the weight. You're going to need to work on this weight. You're noted as obese here, fairly overweight. So it'd be good to get that weight down. I'd say 10, 15, even 20 pounds wouldn't be bad. So you think you can work on your diet?
Okay.
Okay, I think it'd be good to try to watch your diet pretty carefully, particularly watch the fatty foods, high cholesterol, that's shown all over everywhere now, and you've got cholesterol numbers on your food products, so you can go over, just look at the cholesterol levels, especially watch for the saturated fats, to stay away from those, and I think the public's pretty well educated on that, that side of it, so if you can watch that, I think you'll probably be able to knock out, and I think a target of about 15 pounds would be probably pretty good for you. Think you can do that?
Well, I can try.
Okay. Well, I think it'd be real good if you did, because your progress is going so well, and I think you just want to maintain it. Keep going. Okay, exercise, diet. Your meds seem to be working real well. I think you can keep your cholesterol down with that. Be a good idea if you quit smoking.
I don't smoke anyway.
Oh, you don't smoke? Okay, well that's good. You got that going for you. Congratulations. So we don't need to work on that. Drinking. You drink? You a drinker?
Occasionally.
Like how much you drinking?
Not very much.
Well, you may want to drink less than that even. The drink is just not real good for your condition, and
So you get the idea.
It'll hurt with the weight, it'll hurt with the heart. I think everything pretty much, it'd be better if you kind of stayed away from that.
Now, that's an exaggeration, granted. But on the other hand, if we really think about how a lot of healthcare gets spent, it's really stupid stuff like that, where the professionals spend a lot of time telling people stuff that they usually already know, and it's very unclear whether it really does anything. So what's MI? And I'll show you an example in the MI spirit. But let's just talk a little bit about what this thing is. So in a layperson's definition, it's basically a collaborative conversation style for strengthening a person's own motivation and commitment for change. A practitioner's definition, it's a person-centered counseling style to address the common problem of ambivalence about change. And a technical definition, it's a collaborative, goal-oriented style of communication with particular attention to the language of change, designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. That's a mouthful. So what does that all mean? And why is it important? So these days, whether we like it or not, a whole lot of healthcare is about problems that are potentially mediated by behaviors. So what healthcare professionals across the board spend their time doing is talking about things like obesity, heart disease, liver disease, respiratory diseases that are all mediated by factors that can be changed by behavior. Healthcare practice is increasingly about long-term condition management, and motivating people to change behavior is a primary focus in almost all healthcare settings. Okay? So what do we do when we're interacting with people who are doing things that is not good for them? Right? So they're still smoking despite having emphysema. They're still eating junk food despite being obese and diabetic. They're still beating their children. They're doing all kinds of things that they shouldn't be doing. So what do we do? What do we think our job is as clinicians? Explain what they could do differently. advise and persuade them, warn them, scare them, counsel them, right? And when we get fed up, refer them to a smarter person who may be able to do it better. That's what we think. That's what I thought my job was. I did. If you would have asked me 10, 15 years ago, what's my job when dealing with a patient with schizophrenia who won't take his meds, I thought my job was to convince him to take his meds. That's what I thought my job was. I don't think that's my job anymore. I think that's a part of my job. I think there's an appropriate place for this, but it's probably about 5% of the time that I spend with people that kind of stuff is useful, rather than the 95% that I used to think was my job. What is my job? I think my job right now, when sitting across from someone who is engaging in behaviors that are problematic, is two things. One is to figure out where they're at in their readiness and capacity to do something about it. And then the other thing is motivational interview, which I'll explain to you, how to help them do something about it, okay? Now this fits very nicely. I don't know how many of you are familiar with the stage of change model? Does that sound familiar? It's actually a really useful thing to think about. And it's complementary with this stuff. It was developed by people in the smoking cessation world. It was very highly complementary. It's a pretty simple idea. So when I say assess someone's readiness to change, so the way that they do it is so pre-contemplation. Let's take a person who you're seeing because they got arrested for smoking marijuana 2 times or something like that. So pre-contemplation, hey, marijuana is a natural ingredient. It comes from the earth. It's not a problem. I'm better when I'm high than when I'm not high. This is not my problem. This is your problem. There is nothing wrong with this other than that it's illegal. Period. Okay? Contemplation. You know, my kids are 13 and 14, and this works for me, but I'd kind of not like to see them get into it. This is the second time I've gotten in trouble at work. But I got to tell you, Doc, if you were with me, you'd want me to be high, because it's better when I'm high than when I'm not. And I'm a better father when I'm high than when I'm not. But it's a little bit of a problem, and I got to do something. But I'm not really ready to do anything about it. Okay, I'm about to lose my job. My wife is about to leave me. I'm getting in trouble. I got to do something. I don't know what I'm going to do, but I got to do something. It's pretty clear to me I got to do something. Okay, it's been 3 weeks since I've gotten high. I've been going to some AA meetings. I'm not sure that they're good for me, but, you know, and I'm not sure how long I'm going to do this, but I'm doing something. I'm dealing with this issue. I've been sober now for a year and a half. You know, I almost had a slip the other night, and then the other piece of this is that we shouldn't forget is that relapse is a big part of this cycle, and that when people relapse, they can relapse into any of these different stages. So, or I'll use another example. How many of you have dieted and you lose a bunch of weight, right? Well, I've seen people who have gastric bypass surgery and they lose 200 pounds, then they relapse. And it could be, you know what, Doc? I was born a fat person. I'm going to die a fat person. I just got to get used to that. They relapsed into pre-contemplation. Okay? Or someone falls off the wagon on New Year's Eve from their sobriety and they're at a AA meeting the next day. They relapsed into action. Okay? So this idea is just a useful idea of thinking about where people are at in terms of their readiness to deal with a particular behavioral problem. Okay?